Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
Hi, everyone. Welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin. Hi.
So we went a little long recording Tebi, but had a lot of interesting things to talk about. So we split it into 2 episodes, and this is part 2, more of the practical aspects, maybe. I think, James, we got into just really how to choose patients for this, manage toxicities, what do you do when somebody's progressing? We talked about treatment beyond progression. So this is part 2 of that. And there's a bit of bloopers in this one, I think, towards the end, but it's au naturel. Oh,
Well, yeah, and you forgot to mention the wardrobe change as well.
yes. Clearly, this is a post-recording realization that we needed to break this one up. So enjoy part 2, Tebi. Let's see what else
I was just going to ask one more thing on that sort of, and then this story, I don't know if it was in the original paper or not, I can't really remember, about the people who have a best response to progressive disease, right, in the experimental arm versus the control arm, also doing better, right? Is that part of the same story, do you think?
Maybe. So the point being, when you get that first scan and there's progression, do you keep your patient on? And they did these sensitivity analyses where they looked at just the category of patients with progression of disease. And I think they landmarked it from the time of that first scan, which is the right thing to do. And those patients still do better by staying on, Tebi. So even when you're progressing on Tebi, you're doing better than if you were progressing on Pembro, which is sort of the takeaway here. So they treated beyond progression and had an analysis of treatment beyond progression, and there was still a benefit. So there's this consideration to treat beyond progression. It's important to discuss that with the patient. And then we've tried to sort of standardize globally. What does that mean to treat beyond progression? Do you do that indefinitely? Do you do it, until the slope of the curve starts increasing, or what do you do? And there's no hard and fast rule here, but essentially if you have 2 sets of scans that are consecutively saying there's disease progression beyond 20% growth, each time, then perhaps it's reasonable to say we got to switch to something else. But if you have nothing else, and sometimes that's the rub here, is you don't have anything else to offer these patients really, then, it might make sense to stay on it. So that is a nice bridge to tolerability. So when you think about toxicity here, they start in those first 3 doses, step up dosing, it's cytokine release. You're going to see this in 89-90% of patients. The good news is they're almost always low grade. So they're almost always grade 1 or 2. Grade 1 CRS is fever, tachycardia, tachypnea. Grade 2 is, okay, you might be dropping your blood pressure. You might be needing to bolus them fluids to keep their blood pressure up. And grade 3 is that more serious, where you actually really do need medical intervention. You probably need to move them to an ITU, ICU, give them some pressors, give them oxygen, So majority of these are low grade. You can treat the fever, you can treat the tachypnea or observe the tachypnea or the tachycardia. It passes. It's very short-lived. Beyond that, when they're on maintenance, they have none of this. It's pretty rare to get a flare of your cytokine release. You might get it if you take more than a week break. So this is weekly treatment. And if for some reason, because of scheduling, holidays, whatever, you get off that and it washes out, then you might have a problem with that next outpatient dose giving a little cytokine release. And frankly, if you end up missing 2 doses, then you need to start again with the step-up dosing and go back in the hospital, build it back up in the patient's system, just out of an abundance of caution. Rash happens in a lot of these patients. And as you and I had certainly seen, the rash takes a lot of different forms. It can be a spot erythroderma area. It can be total erythroderma. It can be flake. I've had patients just flake the tips of their fingers and the soles of their feet. I've had beefy red, lobster red, groin, intertriginous zone rashes. But just as soon as they come on, by the 24-hour mark, they're gone. And they look terrible and they look really bad and you worry. And then at 24 hours, the patient's getting released, or you're going to check on them and it's already better. You almost don't even have enough time to get dermatology involved because these things are quite self-resolving. So, and that's, I guess, important. Why was I thinking that was important? Because if you're treating a patient beyond progression, one of the things you might be worried about is, I'm treating them beyond progression. Is there really a benefit here? But the good news is there's very little adverse events that you see in that maintenance period. They've now established that they can tolerate it, and you don't have a lot of problems. These patients will often, it's a very quick, 15-minute infusion in the maintenance phase with some monitoring for vital signs. They're out of there. It's quick, and they don't need a port. And they will often say, I feel fine. I don't have any real immune-mediated side effects that we're used to seeing with checkpoint inhibitors. So it ends up being this really interesting balance. Their cancer might be slowly growing. You're telling them there's probably a survival benefit despite this, and they're tolerating it well. So the sum of all of those parts is these patients often will stay on for the long term. And so, that's reasonable. I'm going to pause there and let you jump in with your thoughts, and then I'm going to say some things about some supplementary.
Yeah, well, first question is lobster red really a thing? I'm not sure I've heard that before.
You haven't heard lobster red? Like that really red, bright
No.
red? You've heard beefy red.
No, but of course maybe, or cherry red. But of course, lobster red only applies to cooked lobsters, right? Because obviously they're actually kind of purple in real life before you cook them. But, this is true, obviously. I mean, you've seen...
They're purple.
Sorry?
Some of the rashes are a little purpley.
Oh, so it could apply to both cooked and uncooked lobsters.
A caveat to somebody who's doing this and then doing telehealth check-in with their patient, as I did a few times, because they're, being monitored for 16 hours. So you say, let's have a telehealth so I can see how you're doing. And, oh, you're getting a rash. And then they, stand up to show you their growing rash and pull down their trousers. And all of a sudden now you've got essentially pornography on your camera on your telehealth visit because they've, shown you their goods. But it's bright red, purpley red. And then you say, okay, I'm going to come check on you in 8 hours when I get done with clinic. We'll hold on to you. And by the time you walk over from clinic 8 hours later, that rash is really subsiding. And if you hadn't seen it on, X-rated television yourself, you wouldn't have believed that it was really happening, but it happened. Yeah. So anyway, side story.
So I guess, well, thank you. I mean, I've got a few questions. One would be shape of the survival curves, and that may be a thing for the subsequent follow-up. And of course, the comparator is going to be cutaneous melanoma treated with checkpoint inhibitors. Possibility of very long-term disease control / cure, ? The other, I think, obvious question would be, what if the control arm had been Ipi-Nivo? And then maybe third sort of smaller question is, how common is this HLA type? Is it varying a lot around the world? Do we really know the answer to that?
Okay, good questions. Shape of the survival curve. It's worth mentioning that there has been a 3-year survival paper published on this in the New England Journal of Medicine. This is Jessica Hassel, first author, Paul Nathan, second author. Paul Nathan, senior author, Jessica Hassel, Sophie Paperna-Newman, co-first authors. And this was 2023 New England Journal of Medicine. So the shape of that survival curve, it's coming together a little bit over time. The hazard ratio is now 0.68 instead of that 0.51 that we saw at that original reporting. But I think it's reasonable. You had mentioned in a previous podcast that when you give checkpoint inhibitor to cutaneous melanoma patients, you see this kind of plummet that happens in terms of PFS, I would imagine is what you're referring to. And we see the same. We see the same in uveal melanoma, whatever therapy, frankly, so far. But let me, maybe that's burying the lead for a future turn of events. But for most of our immune treatments in uveal melanoma, you'll see that same very steep drop off in the first 3 months. And that speaks to the median PFS, basically still hovering in the 3-month range regardless. Right. It's important to remember that means median PFS 3 months. That means our 1-year PFS is really bad in this disease. It's about 0% at 3 years, by the way, in both arms of this study. So yeah, I think the shape of the survival curve is what we expect. I don't know if we're seeing a tail yet. but we are still early days. We're just seeing some 3-year follow-up on this. So maybe we'll see that we'll start to tail off. Maybe not. Maybe this is a disease where we don't get the same tail of the curve, but we get this prolongation of life. So maybe we're not curing these patients, but we can comfortably say we're extending life. And by the way, I started my fellowship in 2005, 19 years ago this month. And these patients didn't have anything that were improving their survival. I mean, really, it was a 6-month-ish survival with metastatic uveal. So to think that we're going to 21.6 months, huge improvement, still a long way to go. And we have a lot of work ahead of us. It'll keep us busy for at least another few lifetimes. But that's incredible that we've at least figured out something. And it should also be mentioned, this is first in class. This is a drug that has some efficacy in skin melanoma, but it's not a drug that was used because it worked in skin melanoma. So it wasn't this sort of fell off the wagon. Let's just grab off of that and see if it works, right? It was really standalone. Kudos to the company for seeing that there was a real signal in this disease and investigating it further. Okay, so that was shape of the curve. You asked me something before you asked about HLA frequency.
Ipi-Nivo. What if Ipi-Nivo from the control arm?
Ipi-Nivo had been done? So my sweet colleague from Barcelona, Joseph Pilatz, he really likes this propensity score matching to say, okay, we don't have enough patients in this disease to have all the perfect comparator arms. So we've got to reach into some of the Ipi-Nivo phase 2 data. And he ran a study called GEM 1402, which was Ipi-Nivo frontline setting for uveal melanoma throughout Spain. So because it was frontline, he did his best to basically match these two populations. This was published, let me tell you where this propensity score one was published, or we can put it in a fact check after. It was just published, I want to say, in 2024. But what I can tell you is I don't understand this type of analysis is the bottom line. I don't understand these analyses that try to take cohorts from different study and say, okay, we had to eliminate this amount of patients. And when we get down to this amount of patients, I just don't understand what's happening there. I am willing to trust that it was done properly. I just can't explain it. So it's really hard for me to wrap my head around it. There's a nice figure here. I just don't really know what I'm looking at. And truly what it comes down to the conclusion is even if it had gone up against Ipi-Nivo in the frontline setting would not have meaningfully, or Tebi would have still meaningfully improved survival compared to Nivo-Ipi. That's really the takeaway. I don't know. And we'll talk about that in a future podcast because we have two phase 2 studies, non-randomized, of Ipi-Nivo in this population. And they had slightly different 1-year overall survival, slightly different median overall survival. So TBD. And then I wanted to mention something in the forest plot. So let me see which paper this was in, or we put this in the fact check. But there was some interesting supplemental data, as always is, I think, with New England papers. It behooves people to read the main paper, but don't forget to check those supplementals. There's usually some really juicy things. And when you're limited by a journal in, 2 tables, 2 figures, or 3 tables, 3 figures, some of the really interesting exploratory stuff sits in that in that supplemental. So, okay. Here it is. Okay. So when I look at the supplemental data for most recent New England paper on Tebi, so this is Jessica Hassel, first author, Sophie Paperno Newman, co-first author, there is an interesting figure here, figure S12, that I would love to ask the authors at some point. It's post week 9 overall survival based on ctDNA status compared to baseline. So they have a curve in there of baseline status, but that's what I've told you before, SOTO, science of the obvious. If you have positive ctDNA at baseline, you do worse. And if you have negative, undetectable ctDNA at baseline, that's fine. But really, what about the delta? So what happens to patients by week 9? So they show 3 groups here, when in actuality, in my mind, wouldn't there be 4 groups? So you have the group of patients who are detectable at baseline and still detectable at week 9. So they have the worst survival. You have the group of patients who are undetectable at baseline and or remain undetectable at week 9, so the best survival. And then you have an in between, they're undetectable and somehow they've turned detectable So they have an in-between survival, but there's a fourth group, right? There's the detectable at baseline that is now undetectable at week 9. Are we saying there were none of those uveal patients? I'm intrigued by that. So I was intrigued that I only saw these 3 groups. It doesn't make up the entire study population, so this obviously is a lot of data missing here in patients, but I found that to be interesting. I also found this interesting, table S2. They talk about demographic and disease characteristics of crossover patients. 16 patients crossover. What crossover? What are we talking about? There was no crossover in the study that I'm aware of. So are they talking about people who took Tebi and crossed over to Pembro? I'm so unclear about this, but I found that interesting. So I'll dig a little deep and figure out what that means. We can put it in the fact check. But, my understanding, you would mess up your overall survival analysis if you allowed full crossover of the control arm into experience. So I was stunned when I saw this word crossover here. I didn't know what that meant.
Well, and also, I mean, the vast majority of the patients would cross over at the first scan, most likely. Yeah. So it becomes just a now versus later after the first scan. So it'd be very difficult to see an OS benefit there.
Yeah, so that's why we know it wasn't a crossover design. So I really don't know what it means by crossover. And maybe that's why I'm thinking it's the Tebi people who went on to checkpoint. We'll check on that. Your last question was about, by the way, massively long podcast. We might have to split this in 2 pieces. But your last question was about HLA frequency. And to be honest with you, the company on their website will say that it's about 50% in the Caucasian population. I'm doing some work on that. I think you may also have some of this data. 50% feels like an overreach. As somebody who clinically just types everybody who walks into my uveal clinic, it's not 1 in 2 patients who are positive. And by the way, majority of your melanoma patients are Caucasian, whether we're talking uveal or cutaneous. So it's not 1 out of 2. My gut had always told me it was 1 out of 4 or 1 out of 5 patients. It wasn't really even 1 out of 3. At least that's in the US. So we're looking into this, and I saw a report of maybe a Brazilian cohort of HLA type. So we can maybe try to put that in the fact check. I can pull that article. Brazil obviously is not necessarily predominantly Caucasian, but let's see. I'll read that paper and we can see what they came up with. So I think we're looking at this now, and we're looking at it in bigger data sets to just clarify. And that matters because as we design future trials that are HLA restricted, it impacts your screening number. If you think it's 1 out of 2, you'll just screen twice as many patients as the trial needs to enroll. But if it's 1 out of 3 or 4 or 5, then it's, 3 or 4 or 5x the number of screening. So we've gone really long on a really rare cancer here. I don't know.
No, I think that was nice discussion actually. So we got everything, do you think?
Yeah, unless there's any, real world practice questions, certainly we're...
No, well, I mean, yeah, sorry to interrupt. I mean, I think the biggest real world practice question actually, assuming reimbursement as well, because I mean, certainly we don't have this reimbursed at the moment, at the time of writing here, is about treatment beyond progression. I thought you covered that really nicely actually, because I think for maybe people who are new to this, I think that's one of the biggest difficulties in the clinic. And I guess you also covered nicely the practicalities of how you treat the patients as well, and a couple of tips if they've gone on holiday as well. So that's good.
Yeah.
And we had Juicy and Wimpy, so that's also great. And Lobster Red.
3 inches.
And 3 inches. So yeah. So thank you.
Okay. Very good. Thanks. I should probably have.
Okay, so fact check for Tebi. There are quite a few things that came up in the discussion that we've been back through. So I'll actually, Sapna, let you take us through them, and then if there's anything that comes up, I can jump in. But over to you.
Okay, so we were talking about reason for ineligibility, that 442 were assessed for eligibility, and then 51 did not meet criteria, 13 withdrew for a variety of reasons. So ultimately 378 were randomized. And I was asking the question, what was the reason for that ineligibility? Was it that they didn't have the right HLA or something else? So actually in the Supplemental of New England, and we have said, this is like a tip to fellows, always read the supplemental data, the supplemental figures and tables, because they have juicy information in them. The 442 patients were HLA positive. So it wasn't ineligibility due to HLA, but 51 did not meet eligibility criteria. Interestingly, half of that, 26, did not meet the inclusion and 25 did not meet the exclusion. So the protocol documents included in supplemental, so you could parse through what some of those potential inclusion exclusions were. We also talked about because this is weekly treatment, if a patient misses too many weekly doses, they have to be rehospitalized for that step-up dosing because it's cleared out of their system. So instead of that, because that would be a burden on, hospital resources and then financial resources, whoever's paying for this treatment, what Immunocore has developed is something called KIMMTRAK Connect. KIMMTRAK is the brand name. KIMMTRAK Connect is where a patient would register online, and then they would put in advance, hey, I'm traveling to this other part of the United States or UK. I guess you don't have it reimbursed in UK yet, or Australia or wherever. And then KIMMTRAK Connect will find them a site to do that and will take care of the insurance authorization. So that's pretty helpful. Can't say that I've used that for a patient or had to, but it's there. Incredible. Incredible sound. So then we also talked about the frequency of HLA in the Brazilian population. So this is Andrea Cristina de Mello in The Oncologist. This was published just recently, May of 2024. And so this was frequency of HLA A0201 Brazilian population and how that could impact uveal melanoma treatments, because they're about to get TEBI label there, or maybe they just got it. It's about 21% in the Brazilian population. Caveat, that's not a strictly melanoma or uveal melanoma population. It's from their bone marrow registry. And it's not a majority Caucasian population. And then the last one was the propensity score study of Tebentafusp versus Frontline Ipi-Nivo. And what was the citation for that? This is Joseph Pialat's Annals of Oncology, 2024, March. That's the study that has that interesting figures. Annals of Oncology, not Annals of Oncology, right?
Yeah, need to get that one straight, obviously. Okay, thanks very much indeed, Sapna. Sorry for the emergency vehicles outside, but it's a hospital.
All fine.